Good evening, everybody. I would like to say my sincere thanks to Dr. Mohan Sunil because this is the last of his talk in the series of psychopharmacology. And Dr. Mohan has done immense work. Every week has been a lot of learning for him. And his commitment for this series is unquestionable. He's actually done so much of homework to make sure the take-home points are all covered well. And his appetite for teaching is always shown in the form of interest for this series. And in the last series, I want you to make sure you keep him engaged till the last moment. Keep asking me a lot of questions on the Q&A. And today he's going to talk on a very important aspect of prescription in psychiatry, the drug interactions. So we prescribe medications. We don't know how the body responds, how the body metabolizes. Yet another dimension is the co-prescription of medicines and how each one of the medicines talk to each other. So it's important to understand how they interact so that the metabolism and related issues can be addressed. If there are any adverse effects, sometimes that they can get compounded, that's what we must be aware. Just to make sure we're cautious, this class is going to focus on how we need to evaluate each drug interaction. Over to Dr. Mohan Sunil. You also have a very interesting delegate today, Dr. Ravishankar Rao, as the youngest participant for your series. My respects and good evening to Dr. Ravishankar Rao. Over to Dr. Mohan Sunil.
Thank you. Thank you. Thank you, Mahesh. Thanks to Telearugya and Icon for kind of supporting the whole academic event. I guess this is the last of the series we are coming to, but I think this is the beginning of a lot of knowledge thirst, which all of us will have, is what I think so, because today's talk, I'll try to kind of keep it very simple and clear for all of us to kind of look back and ask ourselves, is that the next level of practice we all get into, irrespective of whether we are budding or whether we are a senior psychiatrist, we all can evolve. So let's talk about something interesting called as drug interactions. Now, why should we, as psychiatrists, first of all, talk about drug interactions? Is drug interactions important for a psychiatrist? Now, we all know mental illness is very, very common. There's no question about it. We also know there are a lot of psychiatric medications which are being prescribed, and the number of people who understand the need of treatment for mental illness is day by day increasing. So that's a good point, which basically means a lot of people in the community might be on some kind of psychiatric medication. The most important other point as a psychiatrist we all would acknowledge is a lot of these patients have comorbid physical health conditions, diabetes, hypertension, obesity, cardiac problems, infections, various kind of medical illnesses are comorbid. And in fact, if you read through any mental illness, whether it's depression, whether it is anxiety, whether it is schizophrenia, whether it is bipolar, all of them can individually increase the risk of comorbid medical conditions. What does it mean for us? It means that definitely as a psychiatrist, we need to know about drug interactions, because we are not the only doctor who is going to prescribe some medications to this patient. There might be a lot of other doctors who might be seeing them parallelly for the diabetic status, hypertensive status, other metabolic conditions, autoimmune conditions, cancer, it doesn't matter, any other physical illness. So it is important for us to understand we are not only be prescribing, the other people also would be prescribing. So just to make things more complex, you need to understand the number of people with mental illnesses who will seek herbal remedies, who will seek alternative cares, whether it's Ayurveda or Siddha or Unani or homeopathy or anything else, is also very, very high. Not just that, a lot of people search on internet and do take some supplements all by themselves. Now, with easy access to online supplements, with alternative medicine growing by itself, so I think it's important for us to understand it is wrong for us to assume that the medicine which we prescribe is the only medicine our patients are taking. Most probably, it is one among the many number of medications they are taking. So it's always good to assume that even though you as a psychiatrist might have prescribed one medication, the patient might be on two or more medications. And when I say medications, supplements can be considered as medications, diet can be considered as medications, other drugs can be considered as medications. So it's important for us to understand we have to expand the horizon of drug interactions and look at it. Now, when you look at drug interactions, many times there might be no effect. See, for example, uh, many times we are tempted to do Google search. Let's imagine there is a patient who's sitting in front of me who's taking some cancer treatment, and he says, "This is the molecule I'm taking." Now, I want to ensure that the medicine I'm going to prescribe doesn't interact with the medicine he is already taking. So if I just do a Google search and put this molecule and the other molecule, most of the times you need to understand these drug interaction websites will show a lot of interaction with various drugs, but is it clinically relevant? Is it important for the patient who's sitting in front of you? Is going to be a question which will never be answered by any of these internet resources. So you need to understand, even though access to internet makes you to pick up drug interactions easily, whether the kind of drug interaction which you're talking about on the website, is it really happening in the patient? Is it clinically relevant? Shall remain quite a question. So that is exactly why a good clinical acumen is to keep documenting of potential drug interactions you think is happening in the patients. And over years of experience and over years of reading, we understand which of these interactions could be very important, and which of these interactions could be just benign and not too very much, because many times there might be no effect. Of course, sometimes there can be lesser effect than what we want. Sometimes there can be more effect than what we want. Not just that, drug interactions sometimes can lead to new effect. Things which we did not even think of can happen in the patients because of the drug interaction. So it is important for us to realize, whenever we are expecting something and it does not go as per expectations, one of the questions in our mind should come is about whether there could be a drug interaction. That's a question for us to always good to ask for. Now, why should we even be talking about this and prime about drug interaction? Because as a clinician, I think until unless we start asking these questions and start looking at a different angle, we might never be able to pick up drug interactions. If we don't look for it, we will never pick up drug interactions. Side effects, most probably we can pick up because the patient is going to come and complain, and we are very tuned to pick up a side effect. But a drug interaction, we're less tuned because most of the times in our busy practices, we don't look for drug interactions. So it's a good idea for us to suspect about drug interactions. But before you suspect about drug interactions, don't miss other things. Like, for example, age can play a role. Every molecule at different ages can work differently. So it's a good idea to look at age, especially when you're dealing with extremities, too young, too old, serious medical illnesses. You need to look at age. Gender can play a role. Drugs can work differently in particular genders, and genetics can definitely play a role. Even though routinely in our clinical practice, we don't do genetics and tests for us to know the impact of it on the drug metabolism, genetics is something which is to be considered. Dietary changes are extremely important. The list of drugs which the person is taking in is extremely important for us to know the effect of various molecules on the body. Now, comorbidities also are extremely important. The cardiac ailments, the metabolic conditions, the hypertension, the kind of epilepsy which the person has. So what kind of comorbid conditions the patient has, and what kind of drugs are they taking? What kind of diet are they taking? Is there possible genetic explanation for the variation in them? So if you ask these questions along with drug interactions, that is when most probably you might pick up a few drug interactions over a period of time. I think willingness to look for drug interactions is a clinical skill. Forget about picking it up. The willingness should be there for us to pick it up. So I think if we have developed that skill, that's more than enough, because over days we learn to kind of deal with the drug interactions in a better way. So when a drug is given, we are looking at a particular effect, right? We are looking at its particular effect or mechanism of action in a particular way so that we want to get a desired effect. But does that happen always? Not necessarily. There is obviously something which we want, but what necessarily happens is failure, toxicity, adverse reactions. You can have side effects, you can have failure of the drug, you can have toxicity of the drug and other problems. So that's something which can happen and which can complicate the whole scenario. So let me ask this interesting question here. As psychiatrists, many times we might put people on 2 or more drugs. Why do you think we might be using 2 or more drugs, combining it in our treatment? Why do you think we might be using 2 or more drugs? Is it to manage comorbidities many times? Is it to augment the effect of primary treatment? Is it to counteract the side effects for the primary treatment? Or is it to fasten the response what we are getting? So why do you think we are using 2 or more drugs as psychotropics combined in a treatment? If you really see, we are all a bunch of clinicians here, and most of us feel we are putting patients on 2 or more drugs because we want to augment the effect or counteract the side effect or fasten the response. Now, let me give an example for us to kind of understand it better. Now, we know that a lot of times depression and anxiety can go hand in hand. And the anxiety could be so prominent that a small dose of SSRI will take its time to work. And especially if you're in a private practice, right, or an outpatient based practice, there is a lot of demand from the patient to get better faster. They're not going to give you that room for you to say, okay, these medications take time, wait 3 to 6 weeks. They want immediate relief, or they will keep switching doctors. So because of the demand, which a lot of times the patients might be putting up, so you need to give faster relief. That makes a lot of times the psychiatrists to prescribe an anxiolytic, at least in the initial few days when they're putting them on SSRI or any other drug to handle anxiety on a long term. So we might add 2 or more drugs in order to fasten the response, or sometimes if the comorbid condition, whether it is a substance use condition, whether it is an anxiety, or whether it is a psychosis, which is comorbid, all those things separately might also be needing 2 or more medications. One of the common places where we want to avoid side effect and prescribe 2 drugs is very commonly as a psychiatrist. When we diagnose psychosis, we start an antipsychotic and we also give an anticholinergic in the morning most of the times to reduce the chances of side effects. We don't want extrapyramidal symptoms. We don't want patients developing dystonia, extrapyramidal symptoms. So we give them kind of 2 or more drug strategy, right? So that is one of the situations where we counteract. Now, augment the effect. Most of the times the augmentation process doesn't happen in the first visit, mostly after a couple of visits when the patient's response is plateaued, but is tolerating the medication well. To augment the effect, we might add on some medications. One of the common strategies in practice where we augment is we are giving antipsychotics. The patient is responded well, he's kind of better. Only thing is he's complaining a little bit of drowsiness, and you're not sure whether decreasing the dosage of antipsychotic will help him. And if you are worried about relapse, most of the times you give a mood alerting substance like an R-modafinil or modafinil in the morning to keep him more active and healthy. So these are common strategies where we might use 2 or more psychotropics in our routine practice. Now, the challenge with this is we assume they are giving in good intention and things should go fine. Will it always go fine? Not necessarily. I remember of situations going wrong very commonly in these patients. Like one of the examples I can give you is there was this patient who was doing very well with schizophrenia-like symptoms, was doing absolutely fine with risperidone at around 4 mg, but only complaint was constantly drowsiness. I was worried about reducing the dosage because after a long time, the patient stabilized at 4 mg of risperidone. I added R-modafinil to help this patient. The patient, once R-modafinil was added, what we found is the patient started becoming a little agitated for first few days. We thought maybe it's a little bit of anxiety. So we asked to take some SOS clonazepam. We thought the anxiety will settle down. In a few days' time, she started having full-blown manic symptoms. So what I'm trying to tell you here is my intention of helping this patient, unfortunately, backfired because the drug interaction led Armodafinil, which was introduced to this patient with psychosis to help the reduction of the side effect, unfortunately precipitated a switch most probably, and the patient had many symptoms. In fact, needed admission in a hospital and treatment and further help. So why I'm giving this example is because even though as psychiatrists we intend to give least number of medications, the moment we start prescribing 2 or more, we should be open to the idea of drug interactions and to look for drug interactions. So when you're talking about drug interactions, with this primed idea, when you're talking about drug interactions, we need to understand we're looking at 2 important things. One is pharmacokinetic drug interactions. Another one is called as pharmacodynamic drug interactions. So what is pharmacokinetic drug interactions? What is pharmacodynamic drug interactions? Pharmacokinetic drug interactions are dealing with mainly absorption, distribution, metabolism, and excretion. Okay, and excretion, absorption, distribution, metabolism, and excretion. That's what pharmacokinetic drug interactions take care of. What do pharmacodynamic drug interactions take care of? This is basically explained by the drug's effect on the target, and drugs effect on the target. Whatever is linked with the absorption, distribution, metabolism, and excretion is taken as pharmacokinetics, whereas what the drug does to the body is pharmacodynamics in action. These are 2 important drug interactions. If you're talking about drug interaction effects, you can talk about 2 important effects. One is the additive or synergistic effect, additive or synergistic or the plus effect. Another one is the antagonistic or opposing or minus effect. Another one is the antagonistic, opposing, or the minus effect. These are 2 important kind of effects which can happen with drug interactions. So when you're talking about drug interactions, I did mention about pharmacokinetics, which is one of the important strategies. So drug interactions commonly we are talking about is induction and inhibition. So it's a good idea to remember that induction is a slower process. It takes time, whereas inhibition is much more faster process and can happen in a very short duration of time. Induction is a slower process. Inhibition is a faster process. It's a good idea for us to remember pharmacokinetic, pharmacodynamic reaction, induction, inhibition. These are terms which are good to remember. Additive or synergistic, and the other one is the opposing effect, which we call as antagonistic effect or the opposing effect. So these are things which you should remember before we go further when you're talking about drug interactions. So let me ask this question. Which of the following drugs is less likely to cause serotonin syndrome? Which of the following drugs is less likely to cause serotonin syndrome? What are the choices given here? Clomipramine, paroxetine, mirtazapine, and bupropion. So which do you think causes least chances of serotonin syndrome, according to you? Sriram, put up the choices. 1, 2, 3, 4. Clomipramine, paroxetine, mirtazapine, and bupropion. Which one has the least chances of causing serotonin syndrome? The answer is obviously bupropion basically increases the norepinephrine levels and the dopamine levels rather than the serotonin levels. So bupropion has less chances of working on serotonin syndrome, whereas the rest of them can cause serotonin syndrome. Paroxetine is nothing but an SSRI, so you might think, okay, it is linked with serotonin syndrome. Mirtazapine again is working on the serotonin receptor, so linked with serotonin syndrome. Clomipramine is a tricyclic, but even though it's a tricyclic, it is one tricyclic which has a lot of serotonin activity. If you remember, clomipramine out of all the tricyclic is most effective in OCD, right? Most effective in OCD. And serotonergic pathways are one of the important pathways that we are talking about in managing OCD. So now you might understand why clomipramine out of all the tricyclics might play a role in OCD. So clomipramine is linked with serotonergic system much more, and please remember it is much more common culprit to lead to serotonin syndrome, which can happen. Now, if you're talking about drug metabolism, you need to understand there is this phase called as phase 1 drug metabolism, there is this phase called as phase 2 drug metabolism. So what is this phase 1 drug metabolism? Basically happens with liver enzymes. Basically, the cytochrome 1, 2, 3 family is the one which plays a role in phase 1, that is linked with the liver. One of the important cytochrome enzymes which we should know is the cytochrome 3A4 enzyme. The cytochrome 3A4 enzyme is an enzyme which basically almost works on 40 to 50% of the drugs which are there in your Goodman-Gilman or any other pharmacology book. In the pharmacology book, all the drugs are there, right? So almost 40 to 50% of those drugs will be related to metabolism through this CYP3A4. So this enzyme is such a varied metabolism action on multiple drugs which are out there. If you're talking about phase 1, you need to understand there are 6 core important enzymes, cytochrome P450 enzymes which are linked. So which are the important 6 enzymes which you should know? One is the cytochrome 1A2, CYP2B6, then the 2C7, 2C19, 2D6, and the 3A4. And the 3A4, 1A2, 2B6, 2C19, and 2C9, 2D6, and 3A4. So these are the 6 core important CYP enzymes which are linked with the phase 1 metabolism. Now, this phase 1, these enzymes are not the only one. There is other enzymes like there is 2E1 which is there. All those are lesser known effective, but this list here, the 6 core, almost takes care of 90% of the drugs which are out there in the market. So 90% of the drugs out there are kind of going to be metabolized by these 6 core enzymes. That's the importance of these enzymes. Out of which I already told you 40 to 50% is just taken care by one enzyme out of this. So can you understand how influential this can be? The moment I say CYP3A4 can work on so many enzymes, so you need to understand that is a place where you can expect a lot of interactions going wrong and leading to trouble. So when you're talking about phase 2, you're talking about phase 2, which is related to conjugation system. It is related to the conjugation system. And what is this conjugation called as? It is also called as glucuronidation. Glucuronidation. What happens in this glucuronidation? The enzymes which play a role in glucuronidation is the UGT enzyme. UGT enzyme, uridine 5 diphosphate, or sometimes they call it as diphospho-glucuronylyl transferase, UGT. That is glucuronidation, which is phase 2. Phase 1 is linked with livers mainly, and it is supposed to be kind of linked with the phase 1. Here we are talking about phase 2, which is glucuronidation process, which is linked with the enzymes UGT. So UGT is phase 2, whereas cytochrome P450 enzymes are the phase 1 enzymes for us to remember. Here, an important point I would like to say, it's a good acronym to remember, LOT, L-O-T, L-O-T. Commonly in alcoholic patients, when you want to give benzodiazepines, you're worried about liver damage and you want to give drugs which are liver safe, right? Which are liver safe. So which are the benzodiazepines which are liver safe? LOT, lorazepam, oxazepam, and temazepam are important drugs which don't work much on phase 1 but directly enter into phase 2. So because it works directly into the glucuronidation process, what you need to understand is liver damage and liver dysfunction is not going to change the metabolism of this. So that is the advantage of these 3 drugs, lorazepam, oxazepam, and temazepam as benzodiazepines. You need to know. Now, we are all a bunch of psychiatrists out here, right? So we need to understand lorazepam is quite commonly prescribed by us, at least in India, in routine practices. So it's a drug which it can be used in people with liver dysfunction, even in elderly patients. It is quite safe because its ability to cause respiratory suppression is much lesser compared to the other benzodiazepines like diazepam or chlordiazepoxide. Now, this LOT will make you remember these three things, which works on the glucuronidation process and is quite liver safe and can be used even in liver dysfunction. The same LOT can be remembered for another reason out there. So what you should remember here is the drugs like lamotrigine. The drugs like lamotrigine, L, O stands for olanzapine, and T stands for tricyclic antidepressants. So please remember lamotrigine, olanzapine, and tricyclics. Again, LOT. These are three important drugs which is still directly the glucuronidation pathway or the phase 2 pathways are very, very important rather than the phase 1 metabolism. So phase 2 metabolism or the glucuronidation pathway is very, very important in these drugs. So that is why this might not be influenced that much with cytochrome enzymes, CYP enzymes, which I spoke about. Which are the three drugs which you should remember, which is related to psychiatry here? Lamotrigine, olanzapine, and tricyclic antidepressants. But please remember, none of the drugs are going to be metabolized by one single enzyme. Multiple different enzymes can play a role, but these are some basic tenets. If you can remember, it can help you to understand and deal with. This is exactly where it's a good idea for you to remember valproate, which we commonly use, right? Valproate is an inhibitor of this glucuronidation pathway. Valproate is an inhibitor of this glucuronidation pathway, and valproate by inhibiting glucuronidation pathway is also known to increase the level of carbamazepine and lamotrigine. Carbamazepine and lamotrigine, will come to it a little later in another slide too. So when we are talking about elimination process, we need to understand there are three important processes of elimination, right? One is the fecal process of elimination, another one is the renal process of elimination, and other modes of elimination through sweat glands and other things are elimination which can happen from our body. Now, what is important as clinicians in psychiatry when we routinely prescribe is there are a few important drugs in psychiatry which requires renal functioning to be at its best. Lithium, I'm sure all of us will remember. So lithium, gabapentin, acamprosate, and amisulpiride are drugs which are very important in terms of renal excretion. They need a good functioning renal system. If there is renal dysfunction, these are the drugs which you should be very careful about using because they can lead to challenges. I'm sure none of us will forget lithium ever, but it's a good idea for us to remember about amisulpiride, acamprosate, and gabapentin. And the importance of acamprosate out here is acamprosate is used in patients with craving for alcoholism, and a lot of alcohol patients can have liver dysfunction. So in liver dysfunction, acamprosate might be safer option, whereas naltrexone, which is also used as an anti-craving agent, but requires your liver functioning to be at its best, might not be a good choice. So that's where acamprosate, because it's renally excreted, might be a better choice in liver dysfunction patients in alcoholic anti-craving substance use management. Understood? So renal dysfunction, these are some important drugs to remember. So the way I'm kind of putting it across where kind of you summarize small points and remember it. I think that's the best way we learn a lot about drug interactions, because drug interactions are quite dry for us to remember it. But as we are learning over a period of time, few drugs which we commonly at least practice and use, if we can kind of remember the safety profile of it, which is safe in liver conditions, which is safe in renal conditions, I think that makes our clinical practice much more better and more effective. So let me ask another interesting question out here. Which of the following SSRIs has least CYP enzyme related drug interactions? Which of the following SSRIs has least interaction of CYP enzymes? What do you think is the answer? Is it escitalopram? Is it fluoxetine? Is it fluoxamine? Is it paroxetine? Which of the following has least interaction with CYP enzyme? I think as a psychiatrist, right, there will be not a single day in our life where we have not written, I mean, when we are working at least, where we have not written a prescription of escitalopram. We write so comfortably about escitalopram. One reason is because we don't need to worry about drug interactions. Most of the times it's well tolerated. We can start with a small dose, escalate it easily. I think escitalopram has made a lot of psychiatrists' life predominantly easy because of its least drug interactions and those. So when you don't know what to do, most probably thinking about escitalopram could be the simplest way to think of dealing with drug interactions. Not necessarily always true, but most of the times that's a simple kind of thumb rule you can follow. So that's known to have the least CYP enzyme related drug interactions. Now, I already mentioned to you only 6 important CYP enzymes in whole of drug interactions. In that, if you specifically look for psychiatry, there are only 4 you should actually remember: CYP1A2, CYP2C9, CYP2D6, and CYP3A4. CYP3A4. These are the 4 most important. If you're reading about psychiatric drug interactions, the most important CYP enzymes which you should know for psychiatry is 1A2, 2C9, 2D6, and 3A4. Most of the drugs will be taken care out by these 4 drugs. Now, when you're talking about the drugs we use, you need to understand the drugs can be substrates, inducers, inhibitors, right? So the drug we prescribe can be acting like a substrate to these enzymes, or it can be acting as an inhibitor or an inducer. It can be acting like a substrate of this enzyme, or it can be acting as an inhibitor or an inducer of this enzyme. So that's how our drug, which we are prescribing, might play a role. It might be a substrate, it might be an inhibitor, or it might be an inducer. So very commonly, I'm sure as a clinician, we always ask this question before we prescribe. Are you taking any medications? Is a common question we all will ask. And when we ask, I'm sure what we mean by any medication in our head. But you would have noticed in your practice that even though you would have asked this question, are you taking any medication? Patients will say, so, no, sir. But later on, when you write the prescription, then they will say, sir, have you written any medicine for sleep? You say, no, I think you have depression. You just take an antidepressant. They say, no, sir, last 2 days I've been taking Restil, I'm taking Alprax, I'm taking Anxit. I thought that I cannot sleep. Would you like to write a sleep medication? Now, you might wonder many times as a clinician, you've already asked them a question, are you taking any medication? But patients say no. But when you write the prescription, they come up and tell you, I'm taking this medication. And many, many times, not just benzodiazepines, they might be taking many other medications, like on long term, a neurologist would have prescribed them a tricyclic, telling this is for your migraine. And they might be taking tricyclic and not even tell you about it. Very commonly. Very commonly, an ENT doctor would have prescribed a tricyclic or small dose SSRI. We know of a lot of times gynecologists prescribing patients with small dose SSRIs because they found these patients to be having anxiety or depressive symptoms. And if the patients are already taking it, they would not even tell you because they think, okay, it's a physician prescribed medicine. It has nothing to do with psychiatrists. What they don't realize here is when you ask, are you taking any drug? You mean any drug. But for the patient, he believes, okay, psychiatrist, why should we be bothered about migraine? Why should we be bothered about some other physical conditions? So it's a good idea if you're worried about a drug interaction to ask, are you taking any medication? When I say any, are you taking any medication for sleep, for any other medical condition, any other condition which has been diagnosed, even if it is thyroid problems, hormonal problems, give multiple ideas. So when you ask this kind of a question, I think you become a great clinician because you will get more data from your patients many times. If you just ask, are you taking any medication? Most of the times it doesn't work. So if you are a practitioner who wants to enhance your skills of drug interaction and figure it out, you should always ask them, are you taking any medicine? And don't forget to specifically mention, are you on any supplements, vitamins? Are you taking any herbal medications? Are you taking any other alternative medications? It is important for us to ask. We might not know what exactly might be the impact of this, but at least it's a good idea for us to keep it in mind so that tomorrow, if things are not improving as well as what we are expecting, we might need to ask ourselves, could it be a drug interaction? So please remember, just don't ask, are you taking any medication? Please try to emphasize the point. When you mean any, what do you really mean by any? And that point will clarify a lot. And that's what a good drug interaction practitioner might pick up. I want all of us to become a good drug interaction expert, picking up cues in our patients and helping our patients the best way possible clinically. So we're talking about substrates. To keep it very simple, in psychiatry, if you look at, there are two enzymes which play a role a lot more. CYP2D6. First I said 6, then I said 4 are important. Now I'm just talking about substrates, but I want to just make it very simple for you, so that if you can remember any of these thumb rules, it will help you in your clinical practice to further build on and become a good drug interaction expert. Because I don't think we will always master drug interactions. It's an ongoing process of learning which we need to be looking at. In simple terms, many or majority of antidepressants are substrates for CYP2D6, whereas a lot of your benzodiazepines are substrates for CYP3A4. So antidepressants are most of the times substrates for 2D6, and benzodiazepines are most of the times substrates for 3A4. So what about our antipsychotics, which are quite commonly written? Now, antipsychotics are a little bit of 2D6 and little bit of 3A4. So that's a good thumb rule for us to remember. When you're prescribing medications, many of your antidepressants could be substrates for CYP2D6. Many of your benzodiazepines are 3A4 substrates. Antipsychotics is a combination of 2D6 and 3A4 substrates. This is a good idea for us to remember. Now, I have been talking to you about CYP enzymes, that is a cytochrome P450 enzymes, or the phase 1 metabolism. I also touched upon phase 2 metabolism, which is linked with the glucuronidation process, the UGT enzyme. It is also important for us to know there is growing literature to talk about this, which is extremely important when you're talking about drug interaction. You need to understand what I want to call it as bouncers of brain. Now, Valentine's Day is coming, right? Just a few days away. So a lot of your pubs and bars will have bouncers out there standing, who don't want to allow single people coming many times, because for them, the business happens when couples come and those. So they kind of have bouncers, and if you're kind of creating trouble, they catch you hold and throw you out of that place, the pub and those. So bouncers are somebody whom we know. Now, what do you mean by these bouncers of the brain? Now, I've coined this term bouncers of the brain for you to understand. There is something called as P-glycoprotein. Now, P-glycoprotein is a transmembrane protein. P-glycoprotein is a transmembrane protein sitting in the membrane area, extending through the membrane. That's why it's called as transmembrane protein. Now, this transmembrane protein is what is called as bouncers of the brain, because this P-glycoprotein is sitting in the epithelial lumen, in the intestine, in the blood-brain barrier area. Anywhere there is an interaction between the inside system and the outside system, there is P-glycoprotein sitting around there. What does this P-glycoprotein do? It's basically a non-specific bouncer. Means what? Whatever abnormal substance, whatever external agents, whatever new drugs, whatever uh, molecules which it doesn't recognize, what it does is like the bouncers in the pubs. What they do is this P-glycoprotein will catch them and throw them out of the cell. They'll say, get out. So it doesn't allow these things to enter. Now, why is this important? Now, this is important because imagine we are giving a drug which is a very significant inhibitor of the P-glycoprotein. If the P-glycoprotein inhibition is very significant, what will happen? Now, it is the bouncer. It removes all the unwanted substances. Now, that is inhibited. If the bouncers are not sitting there, miscreants will enter, right? Troublemakers will enter into the pub. So the same way, your brain, which is taken care by the P-glycoprotein, could be allowing a lot of toxins to enter. So you need to understand that P-glycoprotein is gaining a lot of research and work. For a simple reason is because they realize this P-glycoprotein is genetically linked it can be influenced by the drugs. So that is something you might be coming up whenever you're reading a lot of psychopharmacology in your books. So remember, P-glycoprotein kind of bounces off your brain. Now, whenever you're going to read about P-glycoprotein, you might also come across these terms called as MDR1, which is also called as multi-drug resistance protein or breast cancer resistance protein. Now, a lot of this P-glycoprotein research stems from a study about cancer care and cancer treatment and why cancer happens and cancer fails and chemotherapy works and doesn't work. So you need to understand that's why breast cancer resistance protein is nothing but a P-glycoprotein. MDR1 protein is another type of P-glycoprotein. So they're all similar. You need to understand. Another three terms which you should know when you're talking about P-glycoprotein is, of course, P-glycoprotein should be known, but you should also remember these two terms called as OAT and OCT. What is this OAT? OAT is organic anion transporter. OCT is organic cation transporter. So these organic anion transporters and cation transporters basically transport the anions and cations when you eat or when the substance is there, which is anion, a cation, they play a role in transport. So you might come up these terms whenever you're reading about drug interactions. So if you have an idea of what we are talking about, it can make a lot of sense whenever you're reading across these topics. So in a simple term, when you have the bunch of psychotropics out there, you need to understand majority of the psychotropics will be metabolized through phase 1. Some of them, a few of them are taken care by the phase 2. And of course, you need to understand some of them is renally excreted. So if you ask me, can you teach me drug interaction in just one simple slide? This slide is enough for us to understand. Psychotropics, majority of them will be working through phase 1 metabolism. Some of them phase 2 metabolism. And there are few important drugs which are renally excreted, which you should remember, which will help you clinically to kind of identify such kind of drug interactions. Now, I already highlighted the component of UGT and phase 2 already in one of the slides. I already spoke about lot. I spoke about lamotrigine. Also, do you remember what are what does LOT stand for? One is lorazepam, oxazepam, and temazepam. If you can recall, LOT stands for another 3 molecules which are related to psychiatry, which has a lot of phase 2 metabolism. Which are the 3 LOT molecules which are related to phase 2 metabolism? L stands for lamotrigine, O stands for olanzapine, and T stands for what? Tricyclic antidepressants. So kind of, if you keep recalling those things, it becomes easier for you to pick up whenever you are seeing your patients pretty well. I did also mention to you about renal elimination, lithium, gabapentin, amisulpiride, and acamprosate. So majority of the drugs are taken care by phase 1. Some of the drugs are taken care by phase 2. The renally excreted drugs are very important drugs are lithium, gabapentin, amisulpiride, and acamprosate. This is in kind of simple nutshell for us to remember. So let me ask this question to you. Valproate has clinically significant interaction with lamotrigine. This is due to inhibition of 3A4, induction of 3A4, inhibition of 2D6, or induction of 2D6. Valproate is an inhibitor of what? I'll just show you the slide for you to recall. I mentioned to you that valproate is an inhibitor of glucuronidation pathway. So valproate might have its own effect a little bit on the cytochrome P450 enzymes also, but one of the important things is it is an inhibitor of the glucuronidation pathway, and your lamotrigine is predominantly metabolized in the phase 2 metabolism by the UGT enzymes. So that is the reason why your valproate levels are going to change your lamotrigine. Now, that is the interaction we are talking about here. It is not because of 3A4 or 2D6. It is because of UGT enzyme. To be very specific, it's a good idea for you to remember. If there are postgraduates out there, they might ask you in your exams, so you can easily answer. UGT 2B7 is the interaction which valproate inhibits the UGT2B7. Valproate inhibits the UGT2B7, thereby increasing the lamotrigine levels. Now, valproate is V, right? Divalproate or valproate is V. Is easy to remember. It increases the level of lamotrigine. Because it increases the level of lamotrigine so much, it is always good to cut down the dosage by half. It is always good to cut down the dosage by half when you start lamotrigine. If the patient is already, it's going to quite commonly happen if patient is having bipolar disorder, because you might be giving them valproate. You might think of adding lamotrigine, especially if they have recurrent depressive episodes. You might consider adding lamotrigine. So if you are using lamotrigine, please be careful that you can cut down the dosage by half when you are already giving valproate, because valproate is known to increase the level of lamotrigine. And with the lamotrigine increase in level, that too abrupt increase in level, is dangerous. Why? You know, right? Stevens-Johnson syndrome can happen, life-threatening rashes can happen, you might be in trouble. So it's a good idea for you to always ask yourself before you prescribe valproate, is the patient on valproate? Is the patient on valproate? Is the patient on valproate? Asking that question will make you become a very good drug interaction expert. A very simple thing. Valproate increases the level of lamotrigine. So you should half the dose and give lamotrigine when a patient is already on valproate. So another interaction which you should remember along with lamotrigine is carbamazepine. Now, carbamazepine does almost, it's an inducer of 3A2, right? It's an inducer of 3A2, CYP 3A2. So lamotrigine also is metabolized to some extent with the 3A2. So what this carbamazepine does is it decreases the level of lamotrigine. Carbamazepine decreases the level of lamotrigine. So there you have to double the dosage and give. You have to double the dosage and give compared to valproate. In valproate, you have to half the dosage of lamotrigine. In carbamazepine, you can double the dosage. But in routine clinical practice, right, we are so afraid of the patient developing a rash, which can be especially Stevens-Johnson syndrome and life-threatening. We don't want to risk. So even if the patient is on carbamazepine, a good idea would be is to start low and go. This might not be a great idea to double it up right away. Most probably, you can expect not much of reactions to happen till you hike up the dosage slowly. So carbamazepine, double the lamotrigine dosage, valproate, half the lamotrigine dosage. Definitely you should be double sure that when you actually start patient on lamotrigine, if he's already on valproate, be careful, start with very, very small dose because it can increase drastically. Whereas carbamazepine, even though they say you can double up, I don't know how clinically relevant is it. I don't have personally the guts to hike the good dosage and give lamotrigine, because I don't mind the patient slowly increasing the dosage. I don't want the patient to suffer from Stevens-Johnson syndrome and get into trouble. Next point, which could be interesting and important for us to learn, another interaction is this. A patient is on tamoxifen for breast cancer, post-surgical hormonal management. Which of the following SSRI is preferably avoided? Which of the following SSRI is preferably avoided? So a cancer patient, post-surgery, the doctor thinks tamoxifen will help because it may block the estrogen receptors and kind of make the prognosis better and recurrence chances lesser. So tamoxifen has been given. Maybe the patient has been found to have depression, so you want to give an SSRI. Which SSRI you think should be avoided in this scenario? It's a good idea for us to know that when you're talking about these SSRIs, right? Paroxetine and fluoxetine are two drugs which are very potent CYP2D6 inhibitors. Paroxetine and fluoxetine is a potent CYP2D6 inhibitor. Especially fluoxetine is one culprit which you should remember for drug interactions in many scenarios. Please remember, fluoxetine is a potent inhibitor of CYP2D6, which I just told you, right? Now, fluoxetine is not just a CYP2D6 inhibitor, it also inhibits a few other enzymes. What are the few other enzymes it inhibits? It inhibits the CYP2C9, 2C19, and 3A4. So fluoxetine is a potent inhibitor of 2D6, but it is also an inhibitor of 2C9, 2C19, and 3A4. That's an interesting point for us to remember out here. So paroxetine and fluoxetine are CYP2D6 inhibitors, whereas you need to remember fluoxetine also inhibits other enzymes, that is the 2C9, 2C19, and the 3A4 inhibition can be done by fluoxetine. So that is an interesting point for us to know. Now, talking about sertraline, sertraline and escitalopram are relatively safer to consider in these kind of scenarios. I just mentioned some time back, escitalopram is something which is known to have minimal interaction with the cytochrome P450 enzyme system. So pretty safe SSRI. So you can always go for escitalopram or sertraline. Now sertraline predominantly works on 3A4. 3A4. So sertraline is linked with 3A4 inhibition, but not necessarily with CYP2D6. Understood. The escitalopram is linked with the 2C19 and the 2D6. Not very important because they are not very potent as such. Now, what is important here you need to know is because the paroxetine and fluoxetine is very well known to inhibit the CYP2D6 especially, it is preferably avoided. Even fluoxamine to some extent has a lot of strong interaction with many cancer agents, so preferably avoided. And fluoxamine, you know, is FDA approved for specifically OCD. So very few of us prescribe it to treat depression as such in patients. So you need to understand paroxetine, fluoxetine preferably avoid, especially if the patient is on tamoxifen, because tamoxifen is a prodrug which has to be converted into an active metabolite. That prodrug to active metabolism conversion is by this CYP2D6 enzyme. And you don't want to inhibit that, because if you inhibit that, the conversion does not happen. If the conversion does not happen, tamoxifen will fail, and forget about depression, the recurrence of cancer is going to become high. The patient is definitely not going to be happy about it. So it's a good idea whenever we prescribe an SSRI, ask ourselves, is the patient on tamoxifen? Is the patient on tamoxifen? If the patient is on tamoxifen, consider maybe sertraline, maybe even more better would be escitalopram, rather than definitely avoid paroxetine and fluoxetine. Okay. Now, I have another interesting question here. Antidepressant linked to CYP2B6. Now, this is an enzyme which is not very famous and not much going to be discussed here. But which antidepressant do you think is linked to CYP2B6? It's always good to learn with odd things, right? We always remember odd points and odd experiences, right? So that's why I kind of have spiced our learning through. See, this whole teaching here is a learning process for me also, because I learn along with the teaching which happens. So which is that enzyme CYP2B6 is linked with which antidepressant? Is it mirtazapine? Is it bupropion? Is it citalopram? Is it duloxetine? What do you think is the answer? Please, Shriram, put up the 4 choices for people to answer. Can you guess whether it is mirtazapine, bupropion? Let's see whether most of you know it. 2B6. Very few of us would speak about 2B6 as such. So what do you think is the answer here? CYP2B6 is linked with bupropion, Getting it? Now, it is also important for us to understand bupropion is also linked with CYP2D6. That's how you can remember CYP2D6 is also linked with bupropion. CYP2B6 is also linked with bupropion. So that's something which can help us to remember out there. Now, talking about mirtazapine, mirtazapine is linked with 3 specific enzymes: the CYP1A2, CYP2D6, CYP3A4. CYP1A2, CYP2D6, and CYP3A4 enzymes are all linked with mirtazapine. for us to remember out here. Getting it? If you remember a long time back, in one of the slides we spoke that a lot of antidepressants is substrate to CYP2D6. So you'll see CYP2D6 running around a lot of these antidepressants repeatedly. We'll come to CYP1A2 little later in another slide also. If you're talking in brief about anxiolytic, right? Anxiolytics in simple, you remember the X in anxiolytic, right? So it's a good idea to remember 2C19 and 3A4 are two important enzymes through which anxiolytics are substrates to. Anxiolytics are mostly substrates to 2C19 and the 3A4. Anxiolytics are substrates to 2C19 and the 3A4. What is also important point you need to remember, I'm re-emphasizing here, is LOT. Lorazepam, oxazepam, temazepam, which doesn't work on the cytochrome P450. It is more related to the UGT. We spoke about it in phase 2 metabolism some time back. Right? That's something which we should remember. Now, let me talk to you something very clinically relevant, very commonly prescribed drug, which we have to know when we are doing our practice. These are patients who are taking lithium, right? It's a good idea for us to know some of the important drugs which can increase the levels of lithium and some of them which can decrease the level of lithium. Especially increasing the level of lithium is important because the ones which decrease are the osmotic diuretics and the theophylline and aminophylline can decrease. But what are the drugs which are known to increase the level? If you look at the drugs which can increase the level of lithium are the angiotensin receptor binding drugs, ACE inhibitors, the loop diuretics, the thiazide diuretics, NSAIDs, which is very, very commonly taken over the counter, antibiotics, macrolide antibiotics, tetracyclines. These are drugs which can increase the levels of lithium. So please understand, if they have infection, very high chances the physician they go to is going to prescribe a macrolide antibiotic or a tetracycline is not very commonly used now, but at least macrolide antibiotics sometimes are very commonly used. So it's a good idea for you to kind of look for increase in lithium levels, which could be linked with macrolide antibiotics. NSAIDs, headache can happen, joint pains can happen. Patients might be very commonly having some orthopedic issues or a fracture or something, which can make them end up taking NSAIDs over the counter. So be careful that these NSAIDs could be precipitating lithium toxicity because of increase in that. Lithium diuretics and loop diuretics, ACE inhibitors, and the ARBs are other important drugs which you should know can increase the level of lithium. But can you guess there are two important NSAIDs which don't increase the level of lithium that much. The one which we at least know very commonly is aspirin. The other one is Sulindac. We don't, at least I don't see Sulindac and those being used that commonly at least, but it's at least reported in literature quite commonly that it is an NSAID which can be safe in patients with lithium usage. Aspirin is very commonly used, and aspirin might be not causing that much of lithium level increase. So safe NSAID is aspirin and Sulindac, whereas the rest of them can be having its own problems. So that's something which you should know. Now, it is important for us to remember about CYP3A enzyme. Now, CYP3A or CYP3A4 in specific is an enzyme which almost is taken care by 40 to 50% of the drugs are related to CYP3A. Now, there are one of the very, very important inducers and inhibitors you should know. The important inducers and inhibitors are like that. So if you see, carbamazepine is one called as a pan inducer. Carbamazepine is called as a pan inducer. So it kind of inhibits, it induces the drug CYP3A4 significantly, and it can lead to significant drug interactions. As psychiatrists, the number of prescriptions of carbamazepine we write has, at least I think, has decreased significantly because we have much more effective drugs for bipolar management and those. So we have reduced it, but we need to understand a lot of our neurologists continue to write carbamazepine, and you should look for drug interactions when patients are on carbamazepine. Even oxcarbazepine seems to have significant drug interaction, so it's good to have a watchful eye when somebody is on oxcarbazepine. What are the inhibitors of CYP3A4? This is where a lot of our drugs like fluoxamine, fluoxetine. It is not grape juice which is written here. I've specifically written grape juice because I still remember when I started my psychiatry practice, I had read here and there about drug interactions. I used to remember grape juice, grape juice, grape juice. Please remember, it is not grape juice. I've deliberately written it here to make you understand one important point. It is not grape juice. It is grapefruit juice. Grapefruit is different from the grape juice you get. So grapefruit, I think I've got one opportunity to buy and eat it. It's not commonly eaten by us, at least, but it's quite commonly used by people abroad. So grapefruit juice is what is an inhibitor of CYP3A4, not the routine grape juice you get. So that's different. So please remember, I used to for many years think, okay, I used to tell my patients, okay, be careful, if you're taking grape juice, it can interact. But later on, I realized, okay, it is not grape juice, it is grapefruit juice which they're talking about. So don't make the mistake which I used to make many times earlier in my career. So macrolide antibiotics, azole antifungals, protease inhibitors are those which you should be very careful about while you're using these inhibitors of 3A. Now, we'll move on to something important and practical and useful in our routine practice. Let's imagine there is this patient who is on clozapine, 400 mg per day, and tolerating well, doing well, and he has schizophrenia, possibly resistant. That's why they put him on clozapine. He's taking 400 mg of clozapine, responding well and doing well. Now he gets admitted into the hospital for whatever reason, or he kind of stops smoking on January 1st. Okay, 2021 January, he decides I'm going to stop smoking, and because he has still the craving, he goes to the same shop. He has stopped smoking. He, instead of that, takes 2 cups of coffee and comes back every now and then whenever he has craving for smoking. So this is what happens to this guy. This guy was on clozapine 400 mg per day, stopped smoking on January 1st, composites smoking with coffee. Now, what do you think will happen to his clozapine level? What do you think will happen to clozapine level? Choice 1 will remain same. Choice 2 will increase. Choice 3 will decrease. Choice 4, erratic changes can happen because one side is stopping smoking, another side is taking caffeine, so erratic changes can happen. Clozapine is a great drug, especially in patients with resistant psychosis and all. It's a gold standard drug to be tried. We need to understand antidepressants typically, especially like drugs like fluoxamine, paroxetine, and sertraline, by the action on 1A2, 3A4, 2D6, and 1A2 enzymes, can increase the level of clozapine. So whenever a patient is on any of these drugs, the clozapine levels can further increase than the dosage you are given. We also know that the seizure potential increases whenever the levels increase, right? So it's important for us to remember, if a patient is on clozapine and is also on these drugs, potentially the levels of it could be a little more than the dosages what you're giving. So you need to be careful, and you should be look out for seizure potential and EEG changes in these people. When you're talking about mood stabilizers, valproate as plus minus, some books say it increases, some books say it decreases. So it's kind of difficult to put across. But please remember, carbamazepine, as I already told you, is a pan-inducer. It is a pan-inducer because it induces the metabolism. It decreases the clozapine levels. By decreasing clozapine levels, it might kind of reduce the effectiveness of clozapine. Now, please remember, in a resistant case of schizophrenia where clozapine is managing, we don't want to give a drug which can decrease it and then lead to problem. With antipsychotics, right? Aripiprazole sometimes is known to decrease the level of clozapine, and that's something which you should be careful about. Even though when you're talking about resistant schizophrenia, one of these strategies is to give add-on antipsychotics. Risperidone is commonly given, aripiprazole is commonly tried, but please remember aripiprazole can interact and sometimes reduce the level of clozapine. So you need to think whether you really want to give aripiprazole or should you increase clozapine levels along with it. And you should be careful about it. See, the clinical significance of these level changes are still debatable. So you cannot take the slides and put it into clinical practice right away. But it's good to remember that there can be interactions which can be happening, which might explain why a patient responds or why a patient does not respond. When you're talking about antibiotics, ciprofloxacin, erythromycin are drugs which can increase the level of clozapine. Isoniazid, antitubercular drugs, can increase, whereas rifampin can decrease the level of clozapine. A point to remember here is infection, which I have highlighted there in pink, right? Infection itself can increase the level of clozapine. So somebody who is on clozapine, if they develop an infection, they might be more sedated, or they might have a lot of side effects of clozapine. It need not mean, I mean, if the infection can be controlled quickly, you can reassure the patient that it could be because of the changes in the clozapine levels rather than drastically decreasing it and then they're having a relapse of psychotic symptoms. So it's a good idea for us to remember infection itself can increase the level of clozapine if you're giving clozapine to these patients. Omeprazole is a common drug which a lot of patients might be kind of not even asking the doctor, but they might be taking by themselves. So that can decrease the level of clozapine. So it's a good idea to be careful about it. OC pills is known to increase the level of clozapine. St. John's wort. Now, St. John's wort is something which we generally don't see people using it in India, but there is a growing population of people who have relatives in US. They're coming from US, and if they know that you are in depression, they buy St. John's wort and come and give it to you, telling, take the supplement, it is very useful. Now, I have nothing against St. John's wort, but please remember, St. John's wort is a culprit like your carbamazepine. St. John's wort has a lot of clinically significant drug interaction. So it is a good idea to ask your patients, especially if you know these patients who might potentially be traveling to US quite frequently or having relatives coming from US quite frequently, asking them whether they're taking some supplements, some plant products explicitly is important, because if you don't ask explicitly, patients don't tell you anything. So that's a good idea for us to check with and ask them. Now, when you're talking about smoking, a lot of us will know it has interaction with the clozapine levels and olanzapine levels, but please remember nicotine use, smoking use is a CYP1A2 inducer. Okay, smoking is a CYP1A2 inducer. Most of the times, the mistake we make is we think it is nicotine in it which causes this, but please remember, it is just not the nicotine. The smoke in it has something called as polycyclic aromatic hydrocarbons. Polycyclic aromatic hydrocarbons in the smoke is the one which is the culprit, which leads to CYP1A2 inducer. So it induces the CYP1A2 enzyme and decreases the clozapine levels because of smoking. So a person who's smoking might need much higher dosages, of clozapine, because it is metabolized by CYP1A2. Please remember, it is just not the nicotine. It is the nicotine is not the culprit out there. It is the polycyclic aromatic hydrocarbons, which is an important one. These polycyclic aromatic hydrocarbons not only work on CYP1A2, it works on other enzymes like CYP1A1 and CYP2E1, other enzymes which plays a role. Now, smoking in specific brings about easily reduction in 25 to 50% reduction in these various common molecules we use: clozapine, olanzapine, haloperidol, chlorpromazine. Now, haloperidol, chlorpromazine usage has come down significantly in the recent times, but clozapine and olanzapine are common drugs we use. Please remember, smoking is quite a common comorbid problem in a lot of our patients with psychosis. So be careful of the fact that smoking can interfere into clozapine and olanzapine. Even up to 25 to 50% dosage changes can happen. Level changes can happen when they are increasing or decreasing the smoking usage. Fluoxamine is one drug which is important for us to remember. Caffeine and theophylline is also linked with 1A2 enzyme, and that also has linked with smoking. Now, please remember, if you give a nicotine patch will take care of nicotine and will take care of craving from stoppage of nicotine, but it need not be taking care of the polycyclic aromatic hydrocarbons, right? So your induction or your inducer effect is not because of nicotine, it is because of the polycyclic aromatic hydrocarbon, which I just told you, right? So that is the reason, even if you put a patient on nicotine patch, you might still need to change the clozapine levels, you might still need to change the olanzapine levels when there is a significant change in the smoking behavior. And there is a significant change in the smoking behavior, especially when they suddenly quit smoking or when they are admitted in a hospital. It is important for us to remember that when you admit a patient in the hospital, a lot of patients are no smoking zones, right? Since there are no smoking zones, they're abruptly forced to quit smoking, and they obviously are going to not even come and tell you about it, that they have quit smoking and all. So you need to understand, if they suddenly quit smoking, the inducer effect will be lost. So the clozapine levels can spike up. So that's something which can happen when you admit them into the hospital. Now, caffeine usage, again, I told you caffeine is also linked with 1A2 enzyme. So that is the reason in the question which was asked, right? In the question which was asked, what will happen when he stops smoking, and on that he compensates by kind of taking coffee, he is going to have very high chances of getting into clozapine toxicity. He's going to have very high chances of getting into clozapine toxicity. This is a very, very possible routine thing which can happen in your practice. So it's a good idea for you to be careful about it. Now, some of the patients might be using opioid analgesics. It's very common in US, where a lot of opioid analgesics are commonly prescribed. In India, Tramadol, which is a opioid analgesic, could be commonly used. Please remember the enzyme which is linked with a lot of these opioid analgesics are prodrugs and needs to be converted into an active metabolite, including Tramadol. The enzyme which is needing for its conversion is the CYP2D6, and the CYP2D6 inhibition could be a culprit which can lead to, if you inhibit CYP2D6 too much, the active drug is not formed, so the opioid analgesic effect will not happen. So patient's pain will increase and patient will be in trouble because you were given a CYP2D6 inhibitor. So can you remember which are some of the important CYP2D6 which we use? 2D6. Bupropion is one drug which you should remember. Duloxetine is another drug which you should remember. Fluoxetine is another drug which you should remember. Fluoxamine is also another drug which you should remember. Paroxetine is another drug which you should remember. So bupropion, duloxetine, fluoxetine, fluoxamine, these are all important drugs which can kind of cause opioid analgesic failure because of the inhibition of the CYP2D6 enzyme. One interesting point I would like to highlight here about drug interactions is there is this drug called carbamazepine, right? Now, carbamazepine has an interesting drug interaction. It is an auto-induction system. So carbamazepine induces its own metabolism and destroys itself. It is like destroying its own self. Now, why I'm stressing this point is because, at least in epilepsy patients, we know carbamazepine serum carbamazepine levels are linked with the effectiveness. In bipolar patients, that effectiveness is not very much linked with the carbamazepine levels, but it's a good idea to remember, if you have given carbamazepine at adequate dosages, but if you're not seeing effect in the patient, if you're not seeing effect in the patient, you might decide to remove carbamazepine and add some other mood stabilizer or other anti-epileptic drug. If you're wanting to do that, they always say, because there is a possibility of an auto-induction it is a good idea for you to check for the levels of serum carbamazepine level. If the carbamazepine levels are adequate, but the effect is not there, then you can remove it. If adequate levels have not reached, maybe you should go beyond and give a little more higher dosages, especially if the patient can tolerate it, because auto-induction can explain that the effect of carbamazepine is not seen, even though the dosage is pretty high. So auto-induction, carbamazepine is a good drug interaction point for us to remember. Yeah, keeping in a lot of our patients could have cardiovascular problems. It's a good idea for us to remember QTC prolongation, elderly people, sudden cardiac death, and those things are very common with antipsychotics. I'm not touching about it. We spoke about it in the previous sessions itself. Um, in terms of drug interaction, it's a good idea to be cautious and avoid venlafaxine and desvenlafaxine in patients who have cardiac problems, especially if you are finding them having depression. Try to avoid venlafaxine and desvenlafaxine in patients. So it's a very, very useful strategy for us to kind of look into. Now, we all know when you're talking about drug interactions and those, we're going to talk about alcohol and alcohol related problems. You need to kind of understand one drug which is new into the market, which has very serious contraindication to alcohol intake, is flibanserin. Flibanserin is an important drug which has a serious contraindication with alcohol because it can cause very severe orthostatic hypotension. So patients on flibanserin, if they take, these are patients who are female, hyposexual arousal disorder, where they're prescribed flibanserin. If they take alcohol, can have quite a significant, clinically significant orthostatic hypotension. So it's supposed to be avoided. Alcohol is to be avoided in patients on flibanserin. Now, an interesting point for us to remember here is this small section on oral contraceptive pills. You need to understand, generally speaking, we don't need to worry too much about the interaction between OC pills and the psychotropic drugs, generally speaking. But it's a good idea for us to remember clozapine levels can be increased. Clozapine levels can be increased by the OC pills. So if somebody is on OC pills, it can increase the clozapine levels further. Uh, Valproate is kind of a equivocal, sometimes increase, sometimes decrease. But it is important for us to remember that carbamazepine, oxcarbazepine, lamotrigine, topiramate, carbamazepine, oxcarbazepine, lamotrigine, topiramate can lead to oral contraceptive failure. Now, we know many women might be taking oral contraceptive pills. Of course, sometimes these days OC pills are given even for other reasons like irregular cycles, but it's a good idea to assume that they are using it for contraception. If they're using it for contraception, if these patients are on carbamazepine, oxcarbazepine, lamotrigine, or topiramate, you might lead to oral contraceptive failure by your drug. Your drug might lead to oral contraceptive failure. That's something which might lead to a lot of stress because of an unplanned pregnancy and those things. So it's a good idea to be cautious when you use carbamazepine, oxcarbazepine. The studies which say about lamotrigine and topiramate, the OC failure, it is oral contraceptive failure, is typically saying that very high doses of lamotrigine and topiramate generally lead to OC failure, not at smaller dosages. Or at smaller dosages. It is also important for us to remember the oral contraceptive and pregnancy itself can decrease the levels of lamotrigine. Now, we know pregnancy is something which can be a vulnerable time for depression. Let's imagine a patient is on lamotrigine, and lamotrigine generally is little relatively safer compared to the other drugs which we use as mood stabilizers and those in pregnancy. So we might have put the patient on lamotrigine, patient is stabilized on lamotrigine, patient becomes pregnant. You need to understand effectively the lamotrigine levels can go down, like when oral contraceptives are used, lamotrigine levels also can go down, which can lead to failure of response to lamotrigine. So it's a good idea for us to remember that, and clinically very, very useful. Modafinil or modafinil is not very commonly used in all patients, but if whenever you're using it in patients who are on oral contraceptive pills, please understand OC failure can again happen because of armodafinil or modafinil. So it's a good idea for us to be careful about it and remember these points and address it. Now, I'm not going to get into the whole of MAO inhibitors and the drug interactions and those. They are a separate CME by itself. Let me highlight to you just about serotonin and basically serotonin syndrome, the drugs which can lead to serotonin syndrome. We all know when two SSRIs are added, when two SSRIs are overlapped, one is being removed, one is being added, or two SSRIs are being given for whatever reason it can lead to serotonin syndrome. But the other drugs is SNRIs, which can also, when added, can lead to serotonin syndrome. Tricyclics, especially clomipramine, has a chance of causing serotonergic effect. So we did speak about this earlier in one of the questions, right? So clomipramine is something you should not forget. St. John's wort is another one which can potentially, when added to another SSRI, can lead to serotonin syndrome. Cocaine, MDMA, amphetamine is something which we should not forget, are drugs of abuse sometimes which can lead to serotonin syndrome. Tramadol, methadone, fentanyl, and meperidine are opioid drugs which are specifically also having some amount of serotonergic effect. Don't forget about tramadol, because a lot of patients might be given tramadol by a neurologist or a physician for their pain, and that might actually cause serotonin syndrome along with the SSRI which we might be using. Other than that, dextromethorphan, chlorpheniramine, sumatriptan could be potential culprits. Now, sumatriptan is quite commonly going to be given by your neurologist because of the migraine headache, which is comorbid in these patients. So it's a good idea for us to check with these patients. Now, we all know serotonin syndrome presents with fever, syndrome presents with autonomic instability, serotonin syndrome presents with myoclonic jerks or hypertonus and those things which can happen. But what is important for you to understand is when serotonin syndrome is picking up, patients can be very restless and agitated. How would you differentiate restlessness and agitation due to serotonin syndrome from something like worsening of anxiety? Impossible, almost impossible, until you open your eyes and really look for a drug interaction and ask yourself, could it be a drug interaction? So it's a good idea for us to ask ourselves whether it could be a drug interaction, and then if it's a drug interaction, see whether you could stop one of the serotonergic drugs and kind of help these patients. Because when it's a full-blown serotonin syndrome, everybody will diagnose it. But when it's beginning, when it is kind of starting off, we know the patients could be very agitated, very difficult to pick up clinically in the initial stages itself. So always ask yourself, the patient is worsening, is it because of a drug interaction? Is the patient taking two or more drugs which are all serotonergic and causing trouble? So that question can help us to answer a lot of interesting questions and answers in relation to it. So I'll just highlight to one interesting point, and before we wind up, which of the following antipsychotics should be avoided with food? Which of the following antipsychotics should be avoided with food is the question. So the choices given are ziprasidone, lurasidone, azinapin, and aripiprazole. Now, I have brought in this question is because typically when we talk about drug interaction and all, we're always looking at drug, CYP enzyme and those. I want you to understand that when you're talking about drug interactions, we can look at a lot more other components than just drugs. So that's why I brought in a dietary component here. Now, which of the following antipsychotics should be avoided with food? With food is the question. I see about 85% of them have chosen azinapin. Azinapin is a drug antipsychotic which is to be avoided, is what they have said. Is it true? Let's see the answer. It's a good idea for us to remember that generally speaking, antipsychotics can be given with food. Just before, after, doesn't matter. Most of the patients tolerate antipsychotics pretty well, unlike SSRIs, which can cause nausea, gastric symptoms in empty stomach. This many times doesn't cause, so patients are okay with it. But recommendation, if you see, azinapin is a drug which is taken sublingual, right? Now, sublingual administration, they always say, as per the manufacturers, they say, don't take anything to eat at least for about 10 minutes after you've taken Azinopin. So that's a very crucial point. Very few psychiatrists write Azinopin because of the cost and the mode of treatment which is required. But if you're going to write Azinopin, it's a good thing to give instruction to the patient that they should not be eating or drinking anything hot at least for about 10 minutes from the time they have taken medication. So it's a good thing to avoid and specifically to be mentioned. Otherwise, it's going to be waste because the drug might not work. Lurazidone is specifically recommended by the manufacturers, telling that please take it with a good amount of calories in your diet. Like when you have a good amount of calorie diet, take Lurazidone along with it. That's when best absorption happens and good levels are maintained. So Lurazidone requires you to actually have a decently good amount of 350 plus kilocalories is what they recommend by the manufacturer. So it's a good idea for you to remember these odd interactions and things which are recommended. This makes us become very good clinicians and kind of handle these scenarios much better. Understood. So that's something which we should know. Now, before we wind up, one more question in relation to food, one final question in relation to food before we wind up. Okay, I know you will be hungry, so I'm kind of winding up with food. And I also want to wind up with food for thought with psychopharmacology. So just with this last question, which are the following antidepressants? Which are the following antidepressants absorption reduces without food? Or when you're giving any of these drugs, where should you recommend them to take nice diet or nice food and then take the medicine? It's important for them to have eaten properly. Which of the following drugs? Vilazodone requires you to have decent calories and food content for it to be absorbed very well. Absorbed very well. So I think you need to understand in the same slide. Interestingly, mirtazapine is known to increase the food intake. Bupropion is known to decrease the appetite. So it's good to realize drug interactions are just not about drugs which we prescribe. It's also about various other drugs which other doctors prescribe. It's also about other supplements, diet, and various other things which can be kind of linked to. So before we wind, I thought I will summarize the whole psychopharmacology series with an experience we had. I remember this patient of mine who is actually a medical student, rather a young medical doctor who completed MBBS. And she came and met me telling, sir, I've been diagnosed by previous psychiatrists as having depression. I thought I'll come and meet you and take your opinion and start medication. Now, I spoke to her. She was very lethargic. I started her on duloxetine. Because she had a lot of back pain and other things. I said, okay, let's start duloxetine. Let's see how it goes by. Because your pain can be taken care, your depression can be taken care. What happened was 2 weeks later, she attempted to end her life. Luckily, she survived and she followed up with me. And that's when I was speaking to her. She said, I'm depressed. I'm not doing well. Things are not okay. I'm feeling suicidal. After the consultation, I asked her, do you think the medicine has worsened your depression, or do you think the medicine has increased your suicidal thoughts? Very reluctantly, this doctor, patient of mine, said, sir, I was very embarrassed to tell you that the medicine which you gave actually made me start thinking very suicidal. And that's when the patient opened up and said, sir, after taking the medicine, it worsened. Now, this is a doctor who's sitting in front of me, who was a young doctor, who was reluctant to make me feel bad because the patient felt, how can I tell the doctor that the medicine the doctor has given is making me feel worse? So they didn't want to tell. But when I asked this question, do you think the medicine is causing the problem? The patient opened up and shared. What we did was we stopped duloxetine, and we put the patient on. We wanted to try a different antidepressant. We thought, okay, let's try something like an SSRI, escitalopram. This is a random choice which was done. When we shifted the patient to SSRI, that to escitalopram, the patient did well. The patient reached about 20 mg. was doing fine, but here and there continued to have suicidal thoughts and self-harm attempts and those things. Then that is when we had to bring in lithium for the patient. We had to bring in lithium with an intention to help the patient, because lithium has a lot of anti-suicidal property. I had to talk to the patient and convince this young doctor saying why lithium had to be introduced. I also thought it has mood stabilization property, could reduce impulsiveness, so let's add lithium. So with this escitalopram and lithium combination, patient did beautifully, kind of responded very well, not almost, became completely euthymic and started functioning very well, got back to job and started doing things, everything fine. But the bigger problem we noticed was she started developing acne, and she started becoming anxious about acne and those. She was also looking for an alliance and marriage and those things. So she was very worried about acne coming up now and those. That's when I had to again say, uh, maybe it could be because of lithium. What do you want to do? Shall we consider some other medication, or shall we try to taper off? She was taking a small dose of lithium, more like an augmenting strategy. Can we taper off and see whether you are able to manage only with escitalopram? That's when she said, no, I will handle and see only with escitalopram. So we slowly tapered lithium. She remained on escitalopram many years from then, because she had multiple episodes. We did not want to risk reducing and stopping it. She continued to do well. She got married at some point of time, was in pregnancy. She did not want to take the risk. She was explained the pros and cons of stopping medicine, not stopping medicine, and dealing with it. Why I'm giving this example is this one single patient of mine, I think, has taught more psychopharmacology than anybody else, and any number of hours I might sit and study from textbooks. So I think the best part of whole psychopharmacology is we don't need to sit and study. If we are open, our patients come and teach us, our patients come and kind of pay for it and go back. We can also in the process make their lives the best version of theirs they can be. So I thank Telearogya team. I thank the Icon Life Sciences for this whole series. So before we wind up, I'll try to see whether we can take up some questions out there. And thank you one and all for active participation. I got a lot of feedbacks from different people telling it has been very practical, very useful. It's very humbling. I only hope that in due course of time, you all will be open to look at drug interactions, look at psychopharmacology in a different way, and take it further. I'll take up a few questions and wind up for the day. Okay, the first question which I would like to take up is lithium and renal effects interaction between AC inhibitors and lithium. Okay, it is answered is what sir has put, so I've just left it there. Patient with tamoxifen having severe OCD, what's the pharmacological management? As I said, it's a good idea to avoid your inhibitors like your fluoxetine and paroxetine. Trying escitalopram, sertraline, trying other combinations of behavioral exposure response prevention and other things is always helpful. Now, the best point to always highlight here is we always underutilize psychological interventions in a routine clinical practice. Even though theoretically we write psychological interventions are necessary, the number of people as psychiatrists I've seen we kind of recommend is much lesser. It could be for various reasons, because of lack of quality trained professionals being available to us. But it's always a good idea for us to develop a system around and actually intervene by non-pharmacological strategies equally, because some of them are really, really effective. Is Stevens-Johnson syndrome related to dosage? Interestingly speaking, most of the times lamotrigine related Stevens-Johnson syndrome, they don't say is related to the dosage, but they say the rapidity of increase in the dosage. So if you increase rapidly, the chances of Stevens-Johnson syndrome increases. For example, I want to very enthusiastically help my patient to get better. So I give a much higher dosage of lamotrigine. Then I have to understand that this can lead to Stevens-Johnson syndrome. So rapidity of increase could be a problem. I'll give you an interesting example. One of my patients was started on lamotrigine. When the patient had reached about 50 mg of lamotrigine, we were supposed to go to 75. This patient developed benign rashes, 1 or 2 spots of rashes. Now, I had to talk to the patient and gain the confidence of the patient whether we can increase or wait or do what it is. So what we did was further increase in the dosage because we saw already a rash. We went very slow. Luckily, the patient has reached 200 mga and has remained 200 mg of lamotrigine for many years and has not had a depressive episode in the last few years. But they always say don't rapidly increase. So that's why it's a good idea when you start lamotrigine, be very careful, especially in kind of slowly escalating the dosage. That will take care of it. Isn't SSRI helpful to reduce suicidal thoughts? Absolutely. Sertraline reduces suicidal thoughts, but we all know all SSRIs, in fact, most of the antidepressants have black box warning telling it can, in some patients, increase suicidal thoughts. So only when we ask patients whether do you think your suicidal thoughts are increasing after starting this new medication, some of your patients will nod their heads and say yes. See, they are afraid of talking about medications because they feel that we might get offended when they say against the medicine. So it's a good idea for us to talk to them and ask them. Most of the times it helps to kind of deal with it. Cholinergic load in elderly with psychiatric medication. That's a beautiful question which is asked by Dr. Ravi Shankar Rao sir. In fact, in a month's time, we have a discussion on weaning off psychotropics in Andhra, where they have a CME coming up with the midterm CME, where I'm actually exclusively talking about psychotropic drugs being weaned off, where we will be talking about de-prescribing, not we are always prescribing, right? I'm trying to go talk there about de-prescribing and say how we should stop prescribing sometimes and all. So interestingly speaking, elderly population are very sensitive to anticholinergic side effects. So it's a very, very important point for us to ask ourselves, okay, we have been giving so many medicines. Is it worthwhile? Is it adding any quality of life? Or can I cut down on some of them? And anticholinergic issues are something very, very important because it can lead to bladder issues. It can lead to confusion episodes. It can obviously lead to sometimes orthostatic hypotension, especially in elderly. I think the whole psychopharmacology series, especially I can tell you in the last 1.5 to 2 months, the number of people, especially the elderly population, have picked up orthostatic hypotension is so high just in the last 1.5 to 2 months because I've become more tuned to pick up orthostatic hypotension. Maybe it has always been there, I missed it, but now being tuned to it, I've picked up. So I've reduced some of the drugs which might further worsen orthostatic hypotension. I can tell we reduce the number of falls in this elderly. By reducing the falls in elderly can be helpful. So cholinergic load, orthostatic hypotension are must to look for elderly people whenever we prescribe medications. And it is good to remember lot of over-the-counter drugs because they have cold, cough, fever, they take will have these cholinergic, anticholinergic effects and orthostatic effects. So it's good to look at those points. What could be the reason for increase in suicidal idea after starting duloxetine? Now, see, it's very difficult to say, right? But we all know that almost all of the antidepressants have sometimes an activating property which can happen. And the activating property can happen because of a burst of norepinephrine system, because of a burst of the serotonin system. We all know that SSRIs, especially when started off in small doses, generally will not cause, but it's important for us to know antidepressants have a black box warning to look for it, especially if you're starting in younger people, younger adolescents, and those, be careful. Have a watch for suicidal thoughts. Always check with them. When they say I'm worsening, always ask them whether they were always having suicidal thoughts or as the suicidal thoughts come more in denser or concentration after you have started the medication. When you ask them this clarifying question, I think it has helped us to kind of deal with these people in a much better way. They'll say, no, I used to have suicidal thoughts, but these days it's much more. that is when I think it's a good idea for us to think maybe it's a drug interaction, maybe it's a drug which is causing the worsening, and give a try to stop. And most of the times, because it's the initial time of the starting of medication, it's easy for us also to switch. If we have doubt, I think it's good to give benefit of the doubt to the medicine and shift over and do what is necessary. These are things which are there. I think I've answered most of them. A couple of them I've thanked for the session. Thank you very much. It's great to have interacted with you all. I think I have learned a lot, and in this process, I think if I've kindled some psychopharmacology thought processes in you, I'm happy for it. Thank you, Teli Arogya. Thank you, Dr. Mahesh. Thank you, Icon Life Sciences. Thank you all.